Medurstand Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and after talking about pituitary disorders where there is excess of hormone like acromegaly, gigantism, and syndrome of inappropriate ADH secretion, today we are going to talk about a condition where there could be deficiency of hormones. Now, as the name suggests, hypopituitarism, it is a condition where most of the hormones or all of the hormones are deficient. Now, let's first review what these conditions could be. This is a relatively short video because we don't see hypopituitarism in adults very often. And so I think it will be very basic, but still important for students to know. Now, let's first figure out what these conditions would be like. Now, if all hormones are deficient, all anterior pituitary hormones, including posterior pituitary hormones, are deficient, then the resultant condition would be called panhypopituitarism. Now, when this condition is congenital, sometimes it affects only the anterior pituitary, posterior pituitary may be spared. And even when it is acquired, all hormones are not necessarily equally effective. But of course, we will call panhypopituitarism when almost all hormones, or at least many of them, are deficient. Now, then we have antidiuretic hormone, which is produced by the posterior pituitary, and if that is deficient, in the next lecture we will discuss this condition in detail, and that condition will be called diabetes insipidus. It is different than diabetes mellitus, and in diabetes insipidus there is a lot of dilute polyuria because antidiuretic hormone which concentrates our urine, that is deficient. Then there could be selective deficiency of gonadotropin releasing hormone or follicle stimulating hormone or luteinizing hormone. It could be part of multiple hormone deficiency, and that the condition resulting from deficiency of these gonadotropins and gonadotropin releasing hormone would be called hypogonadotropic hypogonadism. Now this word is little tricky, but you need to understand hypogonadotropic hypogonadism means that patient has hypogonadism. Patient would actually have features of hypogonadism, but the primary problem is in the pituitary gland, the deficiency of gonadotropin. So this is called hypogonadotropic hypogonadism. To differentiate from hypergonadotropic hypogonadism when the problem is in the gonads. So if somebody's testes are destroyed or somebody's ovaries are destroyed, that patient will also develop hypogonadism. But in that case, because the inhibitory effect of testosterone and estrogen on gonadotropin will be lost, so gonadotropin will be actually high. So that condition will be called hypergonadotropic hypogonadism. Now then we have growth hormone. Growth hormone is extremely essential in the early years of life when the growth is occurring. So if growth hormone is deficient, the resultant condition would be called dwarfism. I mentioned in my previous lecture that we do not exactly know any particular role of growth hormone in adults. There may be some, but if the growth hormone is deficient in adults, no much deal. In children, if growth hormone is deficient, the child will not grow properly and the resultant condition will be dwarfism. Of course, there are other causes of dwarfism, so you need to differentiate hypopituitarism from other conditions. Then if ACTH is deficient, then resultant condition will be called secondary hypocortisolism. Secondary referring to the fact that problem is not in the adrenal gland, the problem is in the pituitary gland. Then finally, TSH may be deficient, and if TSH is deficient, then it would result in secondary hypothyroidism. Now, these conditions may present as isolate conditions when there is selective deficiency of these hormones, but many times when the damage to the pituitary occurs, it is actually not very selective. It usually affects all hormones, all type of cells, so there could be a sort of panhypopituitarism. Diagnosis First of all, in any disease, you need to keep your index of suspicion high. You need to know that this condition exists, and only then you can figure out. So, out of many other possibilities, especially in children, if you see somebody who is not growing properly in height, so you need to suspect hypopituitarism. In adults, I think suspicion is little more difficult if somebody present with like lethargy, weakness, and weight loss, uh, sexual dysfunctions, and edema, pallor. I think that is a type of patient when we suspect hypopituitarism. So there will be multiple pituitary hormones deficient and their consequences. Now, if you suspect hypopituitarism, you of course will need to do the hormonal assays, but we also do pituitary imaging because in adults, the cause of pituitary damage is trauma or some malignancy. We need to do MRI of the pituitary to complete the diagnosis. Uh, what is the definition of panhypopituitarism? A condition where all or most of the pituitary hormones are deficient. And the etiology, pituitary gland may be absent congenitally, or the cells which produce specific hormones, though they may be lacking, and trauma, head trauma is common. Head trauma can destroy the pituitary gland. Hemorrhage, sometime because of the growth in the pituitary gland, or sometime without of some bleeding disorder, some infections, there could be hemorrhage in the pituitary gland and that may destroy the gland. You know, our pituitary gland is only of a pea size. So even little bit of trauma, little bit of hemorrhage which can affect that part can lead to hyperpituitarism. Tumor, if there is a tumor which grows from the pituitary fossa, from the pituitary gland, sometimes these tumors are non-functioning. So if there is a non-functioning tumor which grows uh, in the pituitary gland and it keeps expanding, it will compress the normal tissue of the pituitary and it will ultimately destroy. So a tumor which is non-functioning but growing can destroy the pituitary gland. Sometimes there may be a tumor which is functioning but it produces a particular hormone, but it can destroy the remaining pituitary gland and that can also result in deficiency of all those hormones. Then infiltration. Infiltration, there are many conditions where the tissues are infiltrated like histiocytosis, tuberculosis, lymphoma. So I think these conditions can also destroy pituitary. So just imagine any condition, any traumatic condition, malignant condition, hemorrhage or any infiltration of pituitary fossa which can damage the pituitary gland. And it could be congenitally absent also. Clinical features just said dwarfism and lethargy, weight loss, and there are no very specific symptoms. So you need to keep a high index of suspicion to figure out that this could be a case of hypopituitarism. Now, I think once you have diagnosed hypopituitarism, then we need to treat them. Now, the treatment approach is different in adults as compared to children. First, let's take up the children. I don't deal with children very often, but just to complete the presentation, so I am going to discover this part. Now, you know, all these hormones are deficient and children are in the growing age. So unless we replace all of these hormones, they will not grow into a normal adult. So as per theory, we need to replace all hormones. Here ACTH is deficient, but we do not need to replace with ACTH since ACTH is very expensive. ACTH does not have any role in the body except to stimulate adrenals to produce corticosteroids. And corticosteroids are available, so we will replace with corticosteroids, which are the actual hormones which matter as far as patient's child's growth is concerned. ACTH is available but is very expensive. So instead of ACTH, we give corticosteroids. Similarly, the TSH is deficient, but we do not need to replace it with TSH. TSH, I'm not sure if it is available, but it would be very expensive even if it is available. The role of TSH is only to stimulate thyroid gland, and thyroid gland produces T4 and T3, which have these two hormones have tissue effects, and we have T4 available, which is very cheap, so we replace it with thyroxine. Now, follicle stimulating hormone and luteinizing hormones or their analogs are available, but they are expensive. I believe in children, when you have to promote their normal growth of their gonads, and if you want to establish their fertility, then you need to give them estrogen and progesterone, but you will also need to give them follicle stimulating hormone and luteinizing hormones once they achieve or once they approach the age of puberty, to restore their normal cyclical function of uh, 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 menstruation and ovulation. So we would need to give them follicle stimulating hormone, luteinizing hormone, and I believe they would also need also, although if we give these two, testosterone will be produced, estrogen will be produced, but sometimes supplemental dose of estrogen and testosterone is also needed. Then growth hormone, of course, perhaps most essential of all these, growth hormone will be needed to promote their growth, and growth hormone is available, and in children it will be given in the form of injections. So in children, practically speaking, you need to replace all the hormones which are secreted by the pituitary or their target hormones. These two hormones are to be replaced as such, FSH, LH, growth hormones, but instead of ACTH, we give corticosteroids, and instead of TSH, we give thyroxine. The story is a little bit simpler in adults. Corticosteroids and thyroxine are usually sufficient. Now, when you treat such patient, first you have to replace corticosteroids. After a few days, you add thyroxine. If you start with thyroxine, this could actually lead to adrenal crisis, because these patients have deficiency of corticosteroids, but it may not be manifesting. And if you overlook this factor and you start giving thyroxine, their BMR will increase and their requirement for corticosteroid will increase. So although they had small amount of corticosteroid in their body, but once BMR is increased, then they would have a relative deficiency of corticosteroid, and they might end up in a serious condition called acute Addisonian crisis. Both needs to be replaced. Corticosteroids are to be replaced and thyroxine are to be replaced, but in sequential pattern. First corticosteroids, maybe after 6 or 7 days or 2 weeks, then add thyroxine. Then these two hormones need to be continued for life. And then FSH and LH will not be needed if somebody has completed the family and does not want children. So we just can replace the androgen by giving them androgens, estrogen in women and testosterone in men. Uh, if we give them their secondary sex characters will be restored. They will look like females will look like females and male will look like male, and their sexual function will also be restored. And I think that is all what may be needed. But if in some cases their fertility has to be restored, both in men and women, if they need to produce children, then I believe we will have to give them FSH and LH in cyclical form. So in majority, I guess just corticosteroid and thyroxine will be sufficient. The prognosis generally is not very good, because in children, especially in our country, the treatment is very expensive, and most people will not be able to afford it. So even if they are getting treatment, they may not be getting the treatment in the adequate dosage. So most would probably end up in having complication. In adults, I think the prognosis may be better because the treatment is simple. corticosteroid and thyroxine, and they can enjoy a normal life if these two hormones are continued. So this was brief account about panhypopituitarism. As I said in the beginning, it would be a brief presentation. So I'd like to thank everybody for watching this video, and I look forward to see you in my next presentation on diabetes insipidus. Thank you very much.